Hi everyone, and thank you for being with us again in ANT Neuroeducational Webinar Series. My name is Farnoosh Safavi. I'm the Head of Education Department at ANT, and I'll be gladly moderating today's webinar on Remote Point of Care EEG, which will be presented by Dr. Justus Marquetand, who is the co-CEO and co-founder of Celebri GmbH, Germany's first teleneurophysiological company. A specialist in neurology with expertise in clinical neurophysiology and epileptology, he is dedicated to making EEG services accessible to everyone, everywhere. Prior to founding Celebri, he spent nearly a decade at the Neurological University Clinic in Tübingen. Currently, he leads a research group at the Hertie Institute for Clinical Brain Research in Tübingen and serves as a clinical scientific advisor at the University of Stuttgart. After this presentation, we'll watch a relevant demo prepared by ANT Neuro Customer Success Team. A bit of housekeeping points as always. In the course of the presentation, you always have the option to type your questions, which will be addressed at the end of the session as far as the time allows. And like most of our other webinars, you will also be exposed to some poll questions, which we will appreciate if you actively take part in them to make the session more interactive. So Justus, thank you again for accepting our invitation. And without further ado, we are looking forward to hearing your insights about remote EEG in neurohealth care.
Yeah, thank you very much, Banur. I'm sharing my screen and we will start right away. So, remote point of care EEG. I will guide you through the process of what these terms actually mean. Let's start. First of all, what is actually point of care diagnostics? What does this term mean? You have to know, and especially in the healthcare business, it's especially relevant if terms are defined by law, if there's a regulatory definition. And in terms of point of care, there is none. Basically, we understand that it's a rapid diagnostic pretty close to the patient, near to the patient, like a classical analogy you would find everywhere. It's just taking the blood sugar level. But then what is point of care EEG? Again, also, of course, for there, there's no regulatory definition. But if we look a little bit closer into the regulatories, we find at least for one part of it, EEG, regulatory definition. In Europe, it is consistent of that it's recorded brain activity with 2 or more electrodes. So every kind of brain activity where you have at least 2 electrodes, you are allowed to call EEG. Everything else, not. If we read between the lines at FDA announcements or the MDR announcements, you can find something how you would maybe define point of care EEG. Basically, it's as every other point of care device, usually small, very easy to use. So it consists mainly of 1, 2, or just a minimum of buttons, and you have a rapid readout with minimum stuff you need to do. If you look at the so-called guidelines, again, these are not regulatory binding, but they often are referred to that we should follow them. Usually what we say about all EEG diagnostics, there should be 19 electrodes, 19 plus reference and ground electrode. So we have kind of a minimum standard of what a proper EEG diagnostics, not point of care EEG diagnostic, but a proper EEG diagnostic to assess the brain activity should look like. Important to know. So keep 19 in your head. And point of care EEG, or basically all kind of point of care EEG, if you go there and now want to put it somewhere in there, usually what is out there on the market, you will see some of them later on, consist between 4 and 16 electrodes, basically defined for seizure triage, especially status epilepticus. We'll see some of those later, but a full clinical EEG that every doctor or epileptologist, EEG specialist, neurologist can work on remotely, usually consists between 19 and up to as many electrodes as you can fit on the head of a subject or a patient, especially with the use case of epilepsy. One might now ask, okay, why are these guidelines so relevant? Why is are these infos so relevant now? Well, because if you look where you're gonna to use point of care EEG, you need to know your environment you're working in. And usually if you talk to companies, if you talk to remote doctors, they say like, okay, basic, what we have to do is we have to look for the added value here with the medical symbol. You have to look into regulatory details and you have to look for reimbursement. The triangle you have to tackle. But the truth, as far to our experience, is rather that. You have two more, and two of them are pretty relevant: IT compatibility and user friendliness. So you do not only need to tell, hey, point of care EEG gives you some added value for the patient, for the caregivers, so on and so forth. You basically have to fit it in all these key aspects. So it has to be compatible with the IT infrastructure. It has to fit regulatory definitions and has to fit liability laws, has to be somehow reimbursed. So also pricing and whatever has to be fit in, but it should, of course, and this is where added value and reimbursement are working together, should ideally reduce costs or something else. So has this added value, and it should be user friendly as every point of care device. And if you now ask, okay, what kind of systems are out there? It's basically like looking up in the forest. In Germany, we often say you are not able to see the forest in front of all those trees. And for EEG diagnostics, it's basically the same. Of course, there are a few market leaders on that, and especially in the US, this market is way bigger, maybe also due to different regulations and higher reimbursement strategies in the US market than Europe. But there, one example, what you might even easily buy on Amazon is that top up here with some dry electrodes. This is actually not really confirmed in point of care EEG. I would be careful with that. You could use it, but this is more like health and consumer based, whatever kind of metric we are interested in. And what we need point of care EEG in the hospital, well, this will be come up on the next slides. So you might ask now, okay, cool, there are so many systems out there, so I use that one that is maybe the cheapest, the easiest, and so on. No, it's not that simple, and the knowledge that you might have if you have studied neuroscience and think about what you could do, so many cool time series analysis to look at functional connectivity, connectomes, whatever you are interested in, this is actually not mirroring the clinical reality. If you don't know this gentleman, this is Lord Kelvin, and he said something which is pretty relevant if you think about the added value of point of care diagnostics or EEG diagnostics at all. He said something very true. If you can't measure it, well, you can't prove it. What does this mean in terms of EEG? So what can't we measure without EEG? Means like, what kind of information do we assess with EEG diagnostic that no other modality can give us? Or at least not that easy, not that straightforward, and so on and so forth. And if you're working in the hospital, the world is rather simple. Usually you're getting consults with questions like, okay, the patient is strange, means nothing else than an altered mental status, or he was maybe disordered, he has a loss of consciousness, a disorder of consciousness, whatever. He maybe suffered a traumatic brain injury and now is strained. I mean, we can only tell what we know. Or something twitches, has some myoclonic jerks, etc. Basically, what does this question in this often named consultation, it is really that simple, is there seizure or epileptic activity? And this is where I want to remind everyone who maybe was not in the hospital in a clinical setting, the word out there is pretty simple. And so point of care diagnostics, and especially in point of care EEG diagnostic, is actually brutally simple. Following the KISS principle, keep it simple and stupid. Rather, the other question is like, if it's not a seizure or epileptic activity, is the brain function somehow not normal, disrupted? Or how is the sleep, etc., etc.? So everything that is basically not seizure or epileptic activity. Why is this relevant? We know that especially seizure and epileptic activity or disordered brain function has two incidence, or let's call better in this term, prevalence peaks. So at the very early age and at the end of life. Why? At the beginning of life, you have a high prevalence due to any kind of genetic disorders, complications during birth, which all go hand in hand with an epilepsy diagnosis or seizures or any kind of complications. In the end, you have neurodegenerative processes, you have strokes, you have hemorrhagic strokes, you have whatever kind of malfunctions of the brain, which all also go hand in hand with epilepsy. And if you now think about the demographic development, at least in Europe, you can already forecast that we will have a higher and higher need for rapid EEG diagnostics, which basically can detect seizure, epileptic activity, or disrupted brain function. And just as a side note, the demographic change is just about to start. We didn't even start yet. What does seizure and epileptic activity look like? Like this. This is a classical example, not from an old patient, from a rather young one, often generalized epilepsy, where you can basically see what epilepsy is defined of: hypersynchronous sharp spikes and following waves, disrupting the usual background activity, which is alpha before and after it. This is typical. So now you learned already that point of care EEG diagnostics sometimes only have 4 electrodes or 10 or a little bit more. This is now an EEG with typically 19 plus referencing ground in a bipolar montage, so one electrode electric activity subtracted minus the other. And there you can see it right away. If you now imagine only having 10 of those, you would still be able to see and detect that seizure activity. Now it's getting a bit more difficult, where you see like slow waves, or sometimes you see something abnormal that looks sharp, like epileptic spikes, which are pretty defined as sharp graph elements. Most German neurophysiologists say like it is a spike when if you would sit on it, it would hurt. Then it's usually a spike or a sharp wave. If you see this, one hemisphere is normal, the other is abnormal. Now think about again, okay, if you would reduce almost half of those channels, you would still be able to spot it. And also in this case here, you reduce that information, means if you reduce the number of electrodes, you would also be here in this example, or even in this example, have a hard time detecting this. This is basically why the guidelines of the big clinical neurophysiology societies clearly state, okay, we need 19 electrodes and more, because in this case here you see only tiny minuscule spikes here, and here, so P3 minus 0.1 and T5 minus 0.1, you would miss that probably with a reduced electrode number. But most of the point of care EEG devices use a limited electrode number, usually 10 electrodes. They are popular ones out of the market, which just serve as headbands, for example. There you have a high chance of missing those crucial information. Just to have one clear-cut example of something that is not epileptic but still pathological. On the right side, you see a normal EEG, how yours would hopefully look like. Relaxed alpha state, you know that by the textbooks, and on the left, some metabolic encephalopathy to a high increase of ammonia. Of course, this is also abnormal, but if you have this information, this clearly has some impact on your workup on the patient. So now we clarified basically the situation. If you can't measure it, we clarified that measure, but you can't improve it. So let's ask us, okay, what can we actually improve with rapid EEG diagnostics? And basically it boils down to that. If you're faster, that usually means you're better in that brain dysfunctions business. What does this mean? What does science say us? What does the research say us? Well, you simply detect more. You have to know, for example, if somebody experiences first seizure, the time that he arrives in the hospital, usually that seizure is over. It's the first time, nobody has seen it, so you do not have evidence like, was it now a seizure, was it something else, was it just a syncope, just fall down, or whatever. But the truth is, the faster you record an EEG, the higher likely you see the aftermath of a potential seizure, and could diagnose them. Means the faster record after a first seizure, you can detect spikes more likely. And if you can detect this, you are able to name it epilepsy and then treat the patient. Before that, due to the definitions of how you are allowed to diagnose epilepsy, usually after 2 epileptic seizures. But if you have 1 seizure and 1 pathological EEG, you can diagnose epilepsy and start the treatment much earlier on, therefore reducing the risk of recurrent seizures in this individual patient. If you now imagine if you wouldn't have a point of care EEG or any kind of rapid EEG diagnostics in that kind of situation, basically you wait longer in the ICU in a patient, you treat patients longer in the ICU, you do more diagnostics because you need more information about the brain. If you have EEG, this could spare you a lot of time. Based on, of course, if you're also means based process optimization. Also, if you are a doctor in an emergency department and you do not have access to an EEG, which is basically usually half of hospitals of a country, you need to transfer to biggest center that has access to EEG diagnostics and put patients to risk. And again, a lot of money, so you have a reduction costs. And you know, the earlier we can detect not only epileptic spikes, but more an ongoing seizure called status epilepticus, we know the faster we can diagnose it, the better the outcome is. Makes kind of the earlier you can diagnose a disorder, the faster you can treat it, the more likely the better prognosis is. Which also explains why many groups repetitively have found that the ICU stay is almost half if you have access to rapid EEG diagnostic, here abbreviated with point of care EEGs, and thereby also you have reduced complications. Let's move on to IT compatibility, especially give you an Europe example as an example of Germany. The situation is pretty much like this. You have a heterogeneous, very well chaotic IT infrastructure, and you still have fax machines, something the country is pretty famous for. And this solution approach in the past decades has been basically blaming one department, the IT department, of solving that. Means the medical staff, politicians, patients, lawyers, and management forces the IT to solve that Gordian knot. Why is that situation like that? Why is the situation that chaotic and that heterogeneous? Well, if you think of nowadays, medicine consists of numerous machines, devices, and they all come with their proprietary file formats, proprietary hardware, software, and pieces. And basically, the job of the IT department is to mingle them all into one working ecosystem. The problem is here that in that heterogeneous IT ecosystem of a hospital, you would need a lot of compatibilities of the files or the data you are working with that. In terms of EEG files, you have files like EDF, and a good forecast for the future, at least for Europe, that there is the political will to force all manufacturers to convert their files, or at least to have the possibility to convert their proprietary file format into DICOM format, which is the file format for other medical data, as for example MRI, CT data. Means that every kind of software piece of hospital can work with that data. Also, thinking of daily clinical routine, nowadays we do not have pens and papers, but we have stationary personal computers, tablets, laptops, and the doctors want to have a remote viewer compatibility. But this does not necessarily mean that the necessary device here, especially EEG device, is capable of doing so. So it is not necessarily compatible with that, not talking about if it even is Windows, a Macintosh, or whatever. And the medical device needs to be system integrated. So it needs to interface, in Germany, for example, it's abbreviated HL7, needs to fit into patient requirements, support systems, and health records. And in the end, this needs to be secure and compliant. So if you think about that, so given that complications, you have basically one department or one person. I always need to think like, okay, why should this person who's usually already overworked, and forgive me a little bit of sarcasm, but these people do not usually work at Google or at high-ranked IT companies. Why do they should take responsibility and work on it? Especially the point responsibility, reliability becomes now relevant. So it fits nice that we now move on to the regulatory part. You should be aware that you have to follow data security offices, and that any kind of medical device, now the hardware and software part, should align to the MDR in Europe or the FDA. Important, if you're interested, or if you would work in Switzerland, it's also totally fine if you have an FDA approved system, software or hardware, because Switzerland, though it's in the midst of the European continent, does not belong to the European Union. Now let's do one tiny example, quis tentur, Latin, or who is basically liable. Imagine you have an automated point-of-care EEG device, CE marked, cool, one everybody would say. But let's take the scenario, you have a patient on the ICU and it false positively states it's a high risk of status epilepticus. False positively means in this case, the device says it's status epilepticus, but in reality it doesn't is. The doctor applies an anti-seizure drugs to which the patient is allergic. Well, not known before, but of course, why should one know that? The patient dies. Now is the question, who's basically liable for that? Is it the doctor? Is it the device? Who needs to go to prison? There's something, if you are coming from, if you're now listening and coming more from the hardware or the company side, just one hint, the CE mark is just the beginning of a long-term responsibility, doesn't protect you for liability. Because usually the regulatory situation like this, everything gets blurry, and in this scenario, you have, for example, the liability of the manufacturer, which can be liability, although the CE mark, whatever, for the design, production, functions, maybe defective product means maybe one button, one algorithm is faulty, or maybe he gave a wrong instruction. Also for that, people can go into jail. And on the user side, that you are simply not trained. Also, you have a responsibility as a user, that you as a hospital do not have a quality management system to take care that every user properly handles, for example, a point of care diagnostic device, and so on and so forth. For the user, something is really interesting then to partially outsource reliability, at least for the evaluation, and this is then called remote or telemedicine in Germany, or remote treat or telemedicine in English. Basically, at least the German law system does not have a regular definition. It's just remote treatment from ancient times. But basically, it says one thing. You have to have, if you do a remote treatment, so for example, you are a doctor remotely assessing a point of care device, you're always in a treatment context. You have to be medical staff, and this means you are bound to the medical laws. For at least Germany, this means you're not allowed to advertise your business. We are not allowed to do that. And also in terms of reimbursement, you are not allowed to ask for a lot of money and don't do that, because at least in Germany, we have a clear statement saying der ärztliche Beruf ist kein Gewerbe. Literally translating is the job of a doctor is not to be a salesman or merely business. This is up now to the reimbursement topic. So this is the good part of it. Every kind of point of care diagnostic, there's enough evidence everybody can use is that it's cost effectiveness, so we have better outcomes. Of course, you need to convince, or if you're interested in such new device from hospital, it's new because they never had EEG. You have the difficulty that you have to convince hospitals that you have to spend a lot of money at the beginning to have less costs at the end. And you have to be aware, if you're working in Germany or in Europe, that every country has own variabilities. But if you work remotely, please don't fall for the fantasy that, for example, me in Germany could do, is just bound to the German law and just can do any kind of remote evaluation of EEG diagnostic in South US or whatever. You are always bound to the law you're operating in. Means I would be bound to the US. I would start evaluating EEG of US patients. And you have to know about the coverage eligibility. For example, if you're not a doctor or hospital, you are not allowed to ask for a set of money or to do a certain set of diagnosis or operating procedures, OPS. This goes to another point, OPS in German, Operation Prozedurenschlüssel, just claiming a code what you do there. So for example, if you apply an EEG to a patient, you're allowed to code it as 1 - 2 0 7 and so on and so forth with all its specialities. Now the interesting part is, now that telemedicine is on the rise in Germany, way after the US, 10-15 years too late. Now, also you can ask for new features, new OPS, and there's currently this year has started to be that one has been evaluated, that you have remote EEG and epilepsy consultation, and which should be somehow rule of the thumb, be costed or reimbursed by 450 euros. And new updates, this has been declined. Also updates, the reason for that are kind of ridiculous, as I have access to that, but that's how the life as a doctor asking for new diagnostics has to be resubmitted again. Let's go to the last point, the user friendliness. Basically, it's very easy. So just think of your smartphone. That's a perfect example of how user-friendly and intuitive workflow integrated device should look like. Some of point of care devices are, but if you want to have one, if you think of, if you're in our company, man or a manufacturer, think of that point. It is important. Now, just very last minute, just some short example. How do we as therapy do it? Well, basically, we follow exactly the situation that you have remote hospital who has high transport costs for EEG diagnostic for individual patients. And the idea is basically to have it telemedical, to have an EEG in place at the hospitals with EEG cabs, just as the company I'm currently talking in this webinar provides. And we do the outsourcing in the small hospital, just the outsourcing of EEG evaluation. We do this on our data secure cloud with AI assistants and have our doctors in home office. Just as an example, why especially for these EEG foreign, let's say, hospitals work with, well, simply, for example, they have the usage, again, user friendliness, easiness. It's easy to do EEG cabs like the WaveGuard from A&T, which has a very huge reduced application time, and this is data from non-experienced EEG personnel, so no technicians, with a non-significant difference in signal-to-noise ratio. And that's basically it. Thank you very much. And now we would go to the poll questions.